Good morning. I am Joaquín Vicente, a third-year resident in Rheumatology at the Virgen de la Arrixaca University Clinical Hospital. And I'm going to talk to you about the characteristic evaluation of the disease. Here we're going to cover 4 subtopics. First, why it's important to carry out a characteristic evaluation of the disease. Then we'll go over it again, even though my colleague has already discussed it, in the 2 main domains of psoriatic arthritis. Then a series of indices, which I'll tell you right now, you don't need to memorize them all. There are calculators, apps online, we can find them easily. And finally, I didn't want to end my section without talking about comorbidities in psoriatic arthritis. First of all, why is it important to carry out a characteristic evaluation of the disease? Well, look, a phrase I really liked from one of my mentors, Dr. Martinez Ferrin, was, "What you don't look for, you don't find." And why do we need to know the state of the disease? Well, basically because thanks to the fact that we know the state of the disease, we can understand how it's doing, monitor it, determine whether we need to increase treatment, reduce treatment, add or remove things, and therefore guide the treatment. And thanks to this targeted treatment, we will achieve, or at least we'll have a better chance of achieving, remission or at the very least low disease activity. Another important aspect of understanding the disease is the research side of things, which, well, when it comes to testing new treatments, we have indices that objectively, some objective and others subjective. However, in any case, they help us know whether the disease is improving, worsening, or how it's doing overall. Regarding such as 6 domains mentioned earlier by my colleague, we have peripheral arthritis, spondylitis or axial involvement, enthesitis, and dactylitis, cutaneous psoriasis and nail psoriasis. Regarding the domain of peripheral arthritis, the most typical pattern is oligoarthritis, meaning involvement of 4 or fewer joints, which typically presents asymmetrically and predominantly affects the lower limbs. As my colleague already mentioned, it often begins as a monoarthritis of the ankle or a monoarthritis of the knee. Another pattern that we also frequently encounter, as I've already mentioned, is polyarthritis involving 5 or more joints, which often affects small joints symmetrically, similar to rheumatoid arthritis. As my colleague already pointed out, it can have a predominance in the distal interphalangeal joints, and then there is a more aggressive form known as arthritis mutilans, which is typically characterized by osteolysis. Let's take a look at some images. Regarding these domains, arthritis, peripheral involvement, which we mentioned, can very typically present as monoarthritis of the knee. We can see that in this case. As for the polyarthritis pattern involving more than 5 joints, here we can see how practically all the joints in the hand are affected, with a predominance in the distal interphalangeal joints, and a very typical image of mutilating arthritis. With these telescoping fingers, we can see that there has been osteolysis and resorption of the phalanges. Regarding the domain of spondylitis, here we make a bit more of a comparison with ankylosing spondylitis, which is the image on the right, where we can see those syndesmophytes that are referred to as typical, characterized by calcification of the outermost fibers of the annulus fibrosus, the intervertebral disc. We can see that they are much thinner lines, much closer to the disc, whereas in the image on the left, which corresponds to spondylitis from psoriatic arthropathy, we see that the calcifications are much thicker. And it won't be so close to the disc, but rather it will calcify adjacent structures. Another finding in spondylitis. Here I think the image is somewhat unclear, but anyway. On the left side, there was a sacroiliac joint that was practically preserved, whereas on the right side, we can't distinguish where the sacrum ends and the ilium begins. Therefore, these asymmetric sacroiliitis cases are much more typical of spondylitis in the psoriatic spectrum. As for enthesitis, remember that the enthesis is not just the insertion of the muscle tendon into the bone, but it also involves the insertion of ligaments, joint capsule, and fascia to the bone. And here we see an image specifically showing Achilles enthesitis in the left foot. As for dactylitis, which is the same as saying sausage digit, just to remind you, it's the inflammation of what I already mentioned. My colleague, the subcutaneous connective tissue, but it doesn't stop there. There will also be flexor tenosynovitis and joint synovitis. And as I've already mentioned, it is a poor prognostic factor that is associated with greater radiological progression of the disease. As for cutaneous psoriasis, we're all familiar with the typical psoriasis lesions. But since I'm covering the rheumatologist perspective, which is what matters most to us, psoriatic arthropathy, we're going to talk about those types that are associated with or carry a higher risk of developing psoriatic arthropathy. These include those on the scalp, the retroauricular region, the intergluteal fold or perianal area, inverse psoriasis, which appears in the navel, skin folds, and under the breasts. And then regarding severe psoriasis, some do describe it as associated, while others don't make that connection as strongly. But I believe that having a high level of skin activity can also lead to joint involvement. Some images of these lesions, which are associated with a higher risk of psoriatic arthritis than those on the scalp. Here we see them at the base of the hairline, such as even within the scalp itself. In the retroauricular region, which can often be mistaken for eczema, in this case, we can even consult a dermatologist to help determine whether these are psoriatic lesions or some other type of lesion. As for the intergluteal or genital fold, I find this image very interesting for the reasons my colleague has already mentioned. Often these are patients who, if they only have lesions in those areas, might not mention it to you, especially if it's their first time seeing you. But we should still ask and investigate. That's why. Do you have psoriasis on your bottom? In your area? So ask them. Even in future checkups, when we have a bit more trust with the patient, we could even ask if they can show us at least the intergluteal fold. That would be interesting. Many times we have a seronegative arthritis that doesn't quite fit with any known type, and there are no visible lesions. At the spinal level, it doesn't look like ankylosing spondylitis. It doesn't look like Reiter's. It doesn't seem to be associated with inflammatory bowel disease either. And maybe finding a psoriatic plaque in the intergluteal fold or behind the ear, or thoroughly checking the scalp, can give you a clue about what's happening with the patient. Other inverse psoriasis lesions, like those that can appear around the navel or inverse psoriasis in the submammary fold, are also areas you can ask about. Many times patients may feel embarrassed and not want to show them to you. And regarding psoriatic erythroderma, which is a very extensive form of cutaneous psoriasis, as we mentioned earlier, due to its high level of activity, it can also be associated with psoriatic arthropathy. As for the nail domain, here we'll see some lesions on this typical onycholysis, this typical nail destruction seen in psoriasis. These oil spots, which are that detachment of the nail plate, giving the impression, just as the name suggests, as if the nail had been stained with oil. Here's another image, also showing oil spots. And then, as my colleague also mentioned, that pitting, those small indentations that look as if we had taken a pin and pricked the pin into the nail, and we've left that dotted pattern, which is also very typical of psoriasis. And it's not just limited to the nail itself. There can also be subungual hyperkeratosis. Other manifestations, as my colleague mentioned, are not exclusive to psoriatic osteopathy, but are indeed common in spondyloarthritis in general, such as uveitis, which is typically associated with patients who are HLA-B27 positive. And regarding inflammatory bowel disease, she also mentioned it, my colleague mentioned it, and I just want to emphasize that some studies have shown that even in patients with no clinical symptoms, when a biopsy is performed, when a colonoscopy is done, it reveals inflammation at a subclinical level, even though they haven't had diarrhea or shown any symptoms yet. Regarding the indices, as I mentioned earlier, there are calculators, there are apps, we can find them online. There's no need to memorize what needs to be entered or the values. We can find all of that in these tools. We're going to look at domain-specific indices and we're going to look at global indices. And then other aspects also basic regarding the state of the disease, which are also important for patients, such as pain, physical function and ability, quality of life, and later on, some outcome indices. Composite indices that are mainly used in research. Regarding the domain of peripheral arthritis, the two simplest measures are the number of tender joints, which is entirely subjective from the patient's perspective. That is documenting the number of joints the patient reports as painful, and then we have the number of swollen joints, which is more subjective, or at least still subjective. But from the physician's point of view, because it involves identifying how many of these joints are clearly inflamed. A composite index for peripheral arthritis includes, in addition to the number of tender joints and the number of swollen joints, 3 more values. One is completely objective, such as CRP, measured in milligrams per deciliter, and then 2 indices that will be explained to us. The patient rates from 0 to 10, where 0 means they feel well and 10 means they feel very unwell in terms of disease activity over the past week and the level of joint pain during the past week. We input this into the calculator and it will give us a value. Between 0 and 4 points is considered remission, and the higher the score, it would then be classified as low, moderate, or even high disease activity. As for dactylitis, there are numerous indices, but it's enough to simply document the total number of affected digits, that is, to record it in the medical history. If the patient has dactylitis in, say, 2 toes on the right foot, or 2 on the right foot and 1 on the hand, then just make sure to write it down. As for enthesitis, the simplest index, which evaluates just 3 pairs of entheses, is the LEI, the Leeds Enthesitis Index, which assesses 3 pairs. As we mentioned, the lateral epicondyle of the humerus, the medial femoral condyle, and the insertion of the Achilles tendon. And how do we document it, or how are the points added up? Well, it provides some guidelines. They even go as far as to give specific instructions, saying that it's not just about the patient reporting pain, but that they must show pain in response to a pressure of 4 kilograms, which I found interesting, 4 kg. Apparently, that's roughly the amount of pressure needed to make the fingernail blanch. So if the nail blanches and the patient complains, then you score 1 point. Logically, it ranges from 0 to 6, and the more points the patient has, the greater the enthesitis involvement. Another more complex index, which is similar to the previous one, but instead of assessing 3 pairs, we assess 8. This is the spark. So yes, it requires more time. At the axial level, we're going to talk about 2 indices that have been extrapolated from ankylosing spondylitis. The first is the BADAI, in which we ask 6 questions rated from 0 to 10, where 0 indicates low activity and 10 indicates very intense activity over the past week. We can see that the questions include, for example, the first one, which refers to the overall level of fatigue or tiredness. Then it addresses axial involvement, as it asks about the overall level of pain in the neck, back, or hips. And also extra axial involvement, because the next question, the third one, refers to other joints outside of the neck, back, or hips. The fourth question refers to the overall level of discomfort. And then the last 2 questions address stiffness. The first one is about the overall level of morning stiffness. And the second, which is the 6th, is about how long the morning stiffness lasts. How do we calculate it? This index? Well, we add up the scores from 0 to 10 for the first 4 questions, as we mentioned, and then we take the average of the 2 stiffness questions, which are the 5th and 6th. All of that gives us a value. We divide it by 5, and overall it gives us an average from 0 to 10, where a score above 4 is considered to indicate significant activity. Another index also extrapolated from ankylosing spondylitis is the AS-CRP, for which we definitely need a calculator because it involves natural logarithms and such. So let's assess. We need to input 5 data points: back pain on a scale from 0 to 10, the duration of morning stiffness, the patient's global assessment of disease activity, peripheral pain and swelling, and an objective value, which is the CRP. This will give us a value. Where below 1.3, we consider the disease to be inactive. And then, based on the following ranges, we talk about low activity, high activity, or very high activity. And it doesn't stop there. There are even references to decreases of more than 1.1 points or decreases of more than 2 points, which indicate a clinically significant change or an even more significant one. As for the skin domain, which is especially relevant for dermatologists, but we can also use simple indices such as the BSA, which simply involves documenting the body surface area affected in the patient. This is a very simple rule. 1 palm of the hand equals 1%, so we check how many hand palms worth of skin the patient has affected. Less than 3% is considered mild, between 3% and 10% is moderate, and more than 10% is severe. And another index that is used, particularly in dermatology clinics, is the PASI, which not only considers the body surface area, but also evaluates each lesion based on the degree of erythema, scaling, and induration in particular. As for nails, we'll proceed in a manner similar to what we did with dactylitis. That is, simply document and record it in the medical history, as previously mentioned. How many nails are affected? With those typical psoriasis lesions we've seen, such as onycholysis, pitting, or oil spots. And now we move on to more global indices. The first one from the physician's side is the PGA, which ranges from 0 to 10. Scoring system. How much disease activity does the patient have? And then there's a similar measure, but from the patient's perspective. Using a visual analog scale that goes from 0 to 10, where 0 means virtually no disease and 10 means the disease is highly active. Then there are these aspects that shouldn't be overlooked because they are very important to the patient. We care a lot about how much enthesitis, how much arthritis, how much of this or that there is. But for the patient, perhaps these next aspects we're going to look at matter more. Next is how the pain is assessed using a visual analog scale. Again, where 0 means no pain at all and 10 means unbearable pain. Then, another scale to evaluate the patient's physical function, ability, and mobility, the HIQ, which consists of 8 domains that cover basic activities of daily living, such as dressing oneself, getting up, eating, grooming, hygiene, grip, and reaching. So, it covers 8 domains of basic daily living activities and capabilities. Within each domain, we have several questions, and the questions can be answered from 0, meaning no difficulty at all, to 3, meaning the person is unable to do it. Within each domain, we take the question with the highest score, that is, the one indicating the greatest level of disability. We add up the scores from the 8 domains and divide by 8. And this gives us a value between 0 and 3, where 0 means there is virtually no disability, and 3 means the person's life is completely limited. Another scale that goes beyond just this is the how is the patient doing, not only in terms of their basic daily living activities, but it also delves into more psychological and social aspects. It's the PSA-ACOL in which we see questions like, for example, I feel older than I really am, or I get easily irritated with people, I feel dependent on others, I have to limit my daily activities, meaning it already delves into more social aspects. It consists of 20 questions, and the answers must be either yes or no. Logically, the more questions answered with yes, the poorer the patient's quality of life is likely to be. Regarding outcome measures to assess overall how active the disease is, one widely used tool is the MDA, which consists of 7 criteria. If you meet 5 of them, it's considered that the disease has minimal activity, and if you meet all of them, it can even be considered that the disease is in remission. These 7 criteria are the number of tender joints, which should be 1 or 0, the number of swollen joints, also 1 or 0, then the skin domain, which should have a PASI score less than or equal to 1 or a BSA less than or equal to 3, how the patient rates their pain on a scale from 0 to 10, which should be less than 1.5, and how the patient perceives their overall disease activity, less than or equal to 2 on the 0 to 10 scale, the HIQ. This is the scale we've seen is so important, as it refers to physical function and ability. It ranges from 0 to 3, and the value should be less than or equal to 0.5. And regarding enthesitis points, they should be less than or equal to 1. Another outcome index we could also consider is the DAPSA, since we've seen that it provides a set of values by which we can determine whether the disease is in remission or whether it is in a state of low, moderate, or high activity. And then there are other scales from the American College of Rheumatology, which are ACR 20, ACR 50, and ACR 70, mainly used in research and to assess treatment efficacy. These indicate an improvement of 20%, 50%, or 70% respectively, specifically in tender joints and swollen joints. Additionally, the patient must meet 3 out of the other 5 criteria, one of which is patient-reported pain, such as tenderness. Global assessment by the patient, global assessment by the physician, disability. We see that this appears again here. Disability, physical function, and acute phase reactance. And finally, the composite indices, which include CPDI, PAS, DAS, GRACE, and are mainly used in research. And we see how they assess different domains. CPDI, for example, includes axial involvement, cutaneous psoriasis, peripheral arthritis, enthesitis, and dactylitis. But they are too complex to be used in a rheumatology clinic and are mainly used in research. And finally, this was already mentioned this morning. A bit about this, but it's currently trending. HACER. Emphasis on the fact that rheumatologic diseases in general, chronic inflammatory processes, carry a higher cardiovascular risk. In fact, the European Society of Cardiology already includes in the risk modifiers for cardiovascular disease, inflammatory conditions, among them lupus, systemic erythematosus, rheumatoid arthritis, and psoriasis that affects more than 10% or requires systemic therapy, which is the case for a large percentage of our patients. Here, a meta-analysis was conducted looking at the risk of heart attack, for example, in patients with psoriasis, where we see that simply having mild psoriasis already increases the risk of heart attack. And if that psoriasis, instead of being mild, is severe, then the risk of a heart attack increases even further, more. And here is this score table, which we've all probably seen countless times. Just to mention, as we can see, it states that patients with psoriasis who have involvement of more than 10% or who are candidates for systemic treatment, their resulting score should be multiplied by 1.5. In other words, these are patients who have a higher cardiovascular risk than what would normally be expected. Among the classic cardiovascular risk factors, it is essential to control the others, since this is a patient who, by simply having psoriasis, already has an elevated cardiovascular risk. So, without going too deeply into everything, but just to give a few values regarding blood pressure. According to the European Society of Cardiology, blood pressure is considered not elevated when the systolic is below 120 and the diastolic is below 70. In other words, the threshold is being lowered more and more. And here we can simply see how, in a treatment algorithm for arterial hypertension, we observe that in patients in the middle branch, after calculating a score between 5 and 10, if they have an autoimmune disease, they go directly to hygienic and lifestyle measures. And if there is not adequate blood pressure control, even pharmacological measures are considered. Regarding dyslipidemia, just remember that this is also taken from the European Society of Cardiology. We see that after calculating a score, which remember must be multiplied by 1.5, most of our patients should have an LDL below 100. And even more so if they have had or if they have other cardiovascular risk factors. If they have a history of heart attack, stroke, and so on, then it may even be necessary to lower LDL below 55. As for type 2 diabetes mellitus, the general recommendations are to maintain glycated hemoglobin underneath 7%, such as. Regarding obesity, the threshold seems to be typically set at what is considered overweight obesity, that is, in general, having a body mass index below a body mass index of 30. As for classic cardiovascular risk factors, such as smoking and alcohol, logically they should be avoided in these patients who, I emphasize again, have a higher cardiovascular risk due to the fact that they have psoriasis or psoriatic arthritis. And regarding a sedentary lifestyle, it should also be avoided. These patients should be encouraged to engage in regular physical exercise.